All right, guys, welcome to OusProEd. My name is Amrit, and I am super excited to bring the AMC MCQ preparation. And let's start. So before we begin, I just want to talk a little bit about AusProEd. AusProEd is Australian Professional Education, and we help prepare foreign doctors to become registered doctors in Australian healthcare system. So once upon a time, even I was just like you guys, trying to move to Australia, and I was in the same process of doing the AMC exams. And I can completely understand your pain and where you're coming from. And hopefully these sessions will make it a bit easier for you. The courses that we have with AusProEd are designed for foreign trained doctors who are considering the standard pathway with AMC. And they focus on Australian guidelines, and the main aim of these sessions is to help you pass the AMC exams. About the doctors that work at AusProEd, so the main thing is all of us are working in the Australian healthcare system, and the main benefit of that is that the doctors know what they're talking about. They know about the Australian guidelines. They're updated with them. You can have realistic knowledge and insight, and this will help you pass your exam. Okay. Apart from the exam preparation, many people have issues passing the job interviews, or they don't know how to apply for jobs. So that's another part where we're more than happy to help. Say you've got an upcoming job interview coming, not sure what to do, more than happy to pick up the phone and talk to you and guide you what to do. In addition, we've also got another partner who does migration and visas. So if you have any issues with that, we're more than happy to assist as well. Okay, so before starting the MCQ, I think let's talk a little bit about what the exam is and how we can, prepare. So think about the AMC exam as a game. So to play a game or to win in a game, you need to know the rules, right? So AMC is a multiple choice MCQ exam, the first part. And this exam is delivered in 3.5 hours. So it's 150 questions delivered in 3.5 hours. It's a CAT type A question based exam, which means one correct response from 5 options. And all the questions must be answered to complete the exam. So you cannot miss 5 questions and then, pass. All of them have to be finished. Each question must be answered before a further question will be administered. So if you want to go to question 5, you have to answer question 4. Okay. And once you've answered question 4, you cannot go back to question 3, 2, 1. It's done. Okay. So you need to be really, really sure that you have done a good job reading the question, understanding the options, and picking the right option. And marks, when it comes to answering wrong, will not be deducted. So that's a good thing. When it comes to the score, so the score is based on the candidate's ability to answer, because some questions are very easy, some questions are very hard. So how it works is, say 10 people are doing the exam on a certain day. Each person has a different question paper. Say my first question was really, really easy, and I answered correct. The second question that pops up on the screen will be a little hard. The third question will be a little harder. So depending on how I keep answering, the next questions will be populated accordingly. Whereas, say somebody else who's doing the exam next to me, their questions are going to be completely different. Okay. So there's no point cheating or, relying on somebody else in this exam, because it really doesn't help. The core subjects on this AMC MCQ are medicine, surgery, obstetrics and gynecology, pediatrics, psychiatry, population health, and ethics. And okay, so when it comes to the knowledge and understanding, like I said, this is a game, for example. So we need to understand the rules of the game, right? So in order for you to pass, it's important to understand what is the exam testing you on. So say somebody has just completed medical school or they're working as a doctor already, they should have the ability to, be able to do a couple of things. So number one, to be able to provide a rationale for the medical presentation. Number two, understand the normal structure, the function, the development of the human body and the mind at all stages of life, the factors that may disturb these, and the interaction between the body and the mind. You're expected to know the etiology, the pathology, the symptoms and signs, the natural history and prognosis of common mental health and like ailments in children, adolescents, adults, and the aged. You need to also know the common diagnostic procedures, their uses, and their limitations. The management of the common conditions must be known, including the pharmacological side of things, physical and nutritional and psychological therapies. A more detailed knowledge of management is required for those conditions that require urgent assessment and treatment. So as a doctor, you are expected to be able to take care of urgent presentations. You also need to know about the normal pregnancy and childbirth, the more common obstetrical emergencies, the principles of antenatal and postnatal care, and the medical aspects of family planning. The principles of health education and disease prevention need to be known. The principles of betterment of suffering and disability, rehabilitation, and the care of the dying. So these are some of the principles that, you need to know and you need to be competent with. Sorry, I'm just going, okay. When it comes to skills, in this exam, you need to have a few skills. See, guys, the AMC MCQ exam is a very important exam because once you pass this exam, you can actually start working as a doctor. So make sure that, you don't take it very lightly. Many people say that the AMC is a really bad exam. It's unfair. It's pathetic. They hate the exam. They want to pass it, but then they have a lot of hatred with this exam. But the thing that they don't understand is the fact that it's a very important exam, and passing this can give you access to entering the healthcare system. So when it comes to preparation and studying, make sure that you're not taking shortcuts. Make sure that, you're studying with like wanting to understand the system, wanting to understand a certain disease, and not just, wanting to cram the recall and just pass for the sake of passing. Because what happens is you may pass accidentally, you may pass out of luck, you may pass out of your effort, but the next step that's coming, which is the clinical exam, is really hard. So many people don't pass that, especially if, they're relying on recalls and they're not like focusing on gaining the knowledge, then they really struggle in the second part, which is the clinical exam. So the AMC exam is not bad. I think it's a beautiful exam. It gives you a lot of opportunities to, move here, to start working, and it's life-changing, but it all depends on how you take it. So when it comes to skills, you as a doctor need to have the ability to have an organized consultation with the patient to be able to perform an accurate, organized, and problem-focused medical history. So why did I put that there? The reason is when you read some of the questions in MCQ, you may see what is the next best step. What is the next step? Okay, so sometimes they're testing you on your history taking ability. So in order for you to pass that question, you need to have a structure. You need to really think, okay, so I've asked about, say, all the presenting complaint now, maybe I need to know about the risk factors. So maybe the next thing in assessment would be the risk factors. Okay, so try to have like structure. The next thing is the ability to perform an accurate physical and mental state examination. So again, in the MCQs, you may be asked, like, which is the most important examination, or based on your assessment, what do you think is the most likely diagnosis? Okay, so that's again important. Then you need the ability to order appropriate investigation. So in Australia, like in the Medicare health system, it's public. So a lot of, the medical facilities are free. They're given to us free by the government. So as doctors, we can't just order tests because we feel like doing so. We need to have a rationale as to why we're doing what we're doing. So you cannot just order FPE, CRP, LFT. Oh, wait, let me do a D-dimer. You can't do that. You need to have a logic behind why you're doing, because doctors get audited. And questions can be asked like, why are you ordering all these investigations, right? So in countries like in India, in African countries, I've seen that, you can go to a private doctor and get like a MRI brain or anything that you want. It's all private. You can pay out of your pocket and do it. But here it's not like that. You need to have a reason behind what you're doing and why you're doing. And also it has to be cost effective. So it's always stepwise. Then you need to have the ability to interpret and integrate the history and physical examination findings to arrive at an appropriate diagnosis or differential diagnosis. So just because you've ordered a CT brain doesn't mean the story is finished. You need to also understand that it's your job to interpret and, find out why are the LFTs deranged? Why is the troponin high? Why is, this happening? So then you can formulate a diagnosis or a differential diagnosis. Then you need to have the ability to formulate a plan, a diagnostic plan, and to plan the management in collaboration with your patient. So in this, you need communication skills, and also you need to have a solid basis of ethical medical practices. So I will talk about ethics a little bit later, but you do definitely need to have good communication skills. So if you are a doctor who is practicing already, fantastic. What I would recommend is start communicating with your patients, inform them what's happening, why you're prescribing them a certain medication, what are the side effects. Because once you move to Australia, you have to do that every day for every patient. You need to have solid communication skills. You need to have, these abilities to have open communications, open disclosure. So start doing that from now. Next, you need to have the ability to recognize a serious illness and to perform common emergency and life-saving procedures. Like, say somebody's unconscious, what will you do? Somebody has a BSL of 3, what will you do? So you need to recognize and instantly react to these kind of presentations. So you have to be a safe doctor, basically. Like I said, you will be able to start working once you've passed this exam. So they're testing to see, are you a safe doctor? Can you be able to safely practice in the community? Yeah. Then understanding the epidemiology of disease in different population and geographic locations. So what that means is the diseases we have in Victoria. So I'm in Victoria. The diseases here that we see are very different compared to diseases in Northern Territory or in Queensland. So every area has their own problems, okay? So it's good to know these as well. And we will cover them later, don't worry. Okay, then comes the interpretation of the question. So many people, they just go like, oh, this recall came, the answer must be this, click. Oh, I saw this in that recall in that file, let me just click it. Yeah, this must be it, click it. But they don't think, they don't read, because AMC knows that you guys have recalls. AMC are aware of all these, groups and chats and all these things. It's very easy to find out, guys. It's not hard. What AMC also does is they twist around the question, okay? So you may get a recall and you think this is it. Like you don't need to read the question and just answer, but the question may be different. So for example, understanding the question is very important. So learn how to read the question. So first of all, like the way I was preparing back in the day was, I would read if I get the question, I would read the last part first. So for example, what is the most likely next step? I would read question, then I would look at the options, and then I would read the stem. So this was my approach. You can have your own approach, that's fine, but please do not get fooled by what they're asking. So common terms like what are the classical findings or characteristics, or what's typical in a certain disease, whether this is likely, less likely, more likely, frequently, common, uncommon, unusual, or rare, majority of the cases, minority of the cases. So they can twist and ask you, like, which of the following is found in majority of the cases? So you need to know like how to tackle the question, okay? What is the most common presentation, or what's the most likely common presentation, or what's frequently seen based on this x-ray? What is the next best investigation, or what is the next investigation, or which is the least likely condition out of these, or which is the most likely condition out of these? What is typical, what is atypical, essential, predominant? So get a hang of these words. Okay, and practice these words. And when you're studying something or like going through the handbook, try to also understand the pattern, like what is that last line saying, and then you can, go according to that. Like, and in your own exam, be confident, read the question, and make sure you understand what they're really wanting out of it. Okay, wait, I've got a few questions. Okay, you can hear me. Thank you. Okay. Alrighty. So the majority of questions will relate to clinical manifestations of disease, diagnosis, investigation, management, and outcomes. Other questions that, you may see would be like statistics, epidemiology, genetics, to do with clinical trials, public health, ethical, legal, all that. To make life easy, what I would like you to focus on is on the right side. If you can see, there's a list, right? So in a standard examination, you will see questions from these 21 groups. So for example, your exam paper may have dermatology 5%, head and neck 10%, neurology 5%, MSK or orthopedics or rheumatology 10%, circulatory or like heart, vessels 10%, respiratory 5%. So you can have a look at the breakdown, right? So just because you're really bad in neurology doesn't mean you will fail the exam. You still have a 95% chance of passing the exam. So focus on your areas of strength. Excuse me. So what I did when I was preparing for my exam was I made a list of all my areas of weakness. So for example, cardiology, ECGs, investigations, interpreting investigations like CT scans and all that. These were my weaknesses. ECG was my biggest weakness. So I made a really long, realistic list of my weaknesses, and I focused on my strengths first, and then my weaknesses. So that way, at least, I'm being honest and realistic to myself that, look, this is the problem. And to pass the exam, I need 100% score. But if I don't have 100, let me first strengthen my core areas, which I know I can easily pass, and then go to my areas of weakness. So that's that for you guys. Now, when it comes to knowledge, okay. So there are a lot of courses out there. There are a lot of recalls. There are a lot of, people. There are so many things out there. But the thing is this knowledge going to help you? Ask yourself that question. So for example, you are right now investing your time in this session with me, right? Am I legitimate? Or if you are taking a session with somebody else or another company or another group, so are you like going to be able to use this information to take you one step further? Or will you drown with this information because there's no source? So that's a question you should ask yourself. The person who is giving you this knowledge, are they working in the Australian healthcare system? Are they registered as a medical doctor? Because it was interesting. I and my friends, we were looking at a lot of these courses and a lot of these people who run AMC courses, and they've not even worked a single day in Australia. Like they would have passed the exam, but they've never worked in Australia. And it's amazing how they're teaching people how they can pass the exam. So for me, I feel like if I want to learn swimming, I would want to learn it from somebody who is aware of how to swim, who is an instructor, who knows the depths of the water, what strokes to do. And then, I can trust them to teach me rather than, drowning. So the same thing goes with the AMC preparation or any exam preparation. Say you're learning how to drive, but you're driving from somebody who has no idea, like, how do I take understanding right? Okay, they passed the exam, but they don't know, like, oh, what is understanding right again? So, okay, so what can you do? So in Australia, every doctor is registered on APRA. If they are working in Australia, they're registered. You can look up a health practitioner. So if you are going to invest your time, your effort, or somebody is saying, oh, buy my book, I have passed the exam, I can help you pass the exam, you can look them up on APRA and see, are they working in Australia? Are you really a doctor, or you've just like passed your exam and you're sitting in your country and selling courses and wanting to make money? Like, there are all these bogus scams happening out there. So guys, be wise and look up the doctor or whoever it is that you're wanting to, proceed with to prepare. So dangerous knowledge is not good. Because once again, like I said, this exam is a very important exam. Once you pass this, you have already opened yourself the door to working in Australia. So majority of people don't realize this, but this exam is very important. So how do you prepare? So look, you can study on your own and 100% pass the exam. There's no doubt about it, okay? You can go on the AMC website and look at the recommended books, and you can use those as resources. I did not publish that whole list, but you can yourself go on AMC website and check the recommended books, okay? So that's the link where you can go and have a look. Next, I'll just quickly talk about, I don't want to take too much time, but I want to talk about recalls. So recalls, many people swear by recalls. I personally don't like recalls. And there's a couple of people who messaged me. They're like, oh, are you doing recalls? And I'm like, no, please don't waste your time if you are wanting recalls, because that's not what I'm doing. So I don't believe in recalls. Reason being, I have seen so many cases in my work life where somebody got a job, they've come to work and say they're working at the emergency department. They're so lost because they have no idea what's happening. Life is not a recall, you guys. Like when you start working, you need to have a solid understanding and a good foundation on how you can work. So real life scenario, you may pass your exam. You definitely may pass your exam. You may get a job somehow. You may crack the interview somehow. But when you start working, life is not a recall. I promise you. It's like building a house. To build a really good house, you need a solid foundation, okay? If you don't have this foundation, no matter what you do, your house is not going to be stable and it will not sustain. So the sooner you understand that, the better your life will be in the long run. So let's have a look at this question. Sally is a 15-year-old and has 3 siblings called Scott, Sean, and Sam. Her mother's name is Susan. Sally is the middle child and often feels her parents love her siblings more than her because they all don't have an autosomal recessive trait, which she has. What is Sally's father's name? Is it Simon? Is it Mark? Is it Luis? Is it Daniel? Or is it Mike? Ha, ha, ha. So this is a very stupid question, isn't it? Because it makes no sense. That's why I put it here. I can be a little silly sometimes, guys. Excuse me. So the recalls are just like this. They make no sense. So somebody went and did the exam and they came up with something and they put it out on the internet. And in reality, it makes no sense. So please spare yourself and study properly, okay? because you are going to be working with human life, which is not a recall. Okay. Again, same question. Sally is 15 years old and has 3 siblings called Scott, Sean, and Sam. Her mother's name is Susan. Sally is the middle child and often feels her parents love her siblings more than her because they all don't have an autosomal recessive trait, which she has. Which of the following diseases could Sally have? Could it be GBS? Could it be pulmonary hypertension, cystic fibrosis, Marfan's, autosomal dominant polycystic kidney disease? So over here, if you have a little bit of, basic information from med school or from, your work life, you can still somehow pass this question because you have a little bit of an idea, okay, which is an autosomal recessive condition, right? So there you go. So we can tell with confidence that GBS is a disease that attacks the immune system. So it cannot be that. Pulmonary hypertension is not, again, a autosomal recessive condition. So I can take that out. Cystic fibrosis, maybe. Marfan syndrome, maybe. Autosomal dominant polycystic kidney disease, maybe. So then comes your knowledge. You can eliminate in MCQs, what happens is usually 1 or 2 options are always dummy and you can eliminate them right away. So we've right away thrown away A and B, okay? Remaining C, D, E. So C, D, E is your knowledge now. Marfan syndrome is an autosomal dominant condition. So in this, people have really long arms, legs, fingers, but the stem did not talk anything about that. So I will take that out as well. Then comes ADPKD. So again, this is a disease that happens to people in, their midlife. And this person is only 15 years old. So not going to be this. Next is cystic fibrosis. So, this is a common condition. It's inherited autosomal recessive, and it's a complex disease. It can affect a person's lungs, GI tract, pancreas, liver, sinuses, sweat glands, kidneys, everything. So, okay, we got this. So see, you can deconstruct a question and answer it if you know a little bit about the knowledge. Okay. Moving on. Let's move on to ethical principles. So when it comes to practicing in Australia and also the exam, ethics is a part of the preparation which you have to do. So when it comes to ethical practices, you need to know that we have 4 key principles which we focus on. First is justice. So patients should be treated equally, and there should be equity of access to services regardless of place of residence, ethnicity, gender, religion, or disability. Justice is very important when it comes to practicing medicine. Respect for autonomy. So the right of an individual to self-determination, including privacy and confidentiality. So when it comes to working as a doctor in Australia, many IMGs struggle with this part. So they don't understand confidentiality that well. Say, for example, you are seeing I'll tell you a clinical exam scenario. So there's a clinical, not too long ago, a student of mine had an exam where there was a 18-year-old with drug overdose, and your task is to inform the father about the diagnosis. So out of respect for autonomy, you cannot do that because this person is 18, first of all. Secondly, you need to respect their privacy and confidentiality. You cannot go and tell the father that your son is in hospital because of a drug overdose. Does that make sense? So they kind of trick you in these scenarios in both MCQ as well as clinical exam to see if you understand that. And also confidentiality, say somebody has cancer or HIV, you cannot go and tell their family member or have, unless the patient wants you to, but otherwise, no, okay? So beneficence is taking positive action to do good. Non-maleficence is do no harm. So these are just some basic, ethical principles that we need to be aware of. Next is consent and informed decision making. So what is consent? So for consent to be valid, it needs to be given freely. This includes avoiding pressurizing the patient through like failure to provide sufficient time for the patient to consider matters, or failing to recognize other pressures, for example, like from family. Involve disclosure by the doctor of sufficient information, including material risks. Be specific for the proposed procedure. Consent should be given by a person who is competent to consent. So the person needs to be competent. I will make you understand what that means. This will ordinarily be the patient, unless the patient has like a condition and they're believed to be not competent. Consent needs to be like, for example, like say if you're going to start an IV line for somebody, you need to gain consent. You have to explain to them why you're doing it, what is the danger, what are the pros, what are the cons. So then you can be like, all right, are you happy for me to do it? Okay, and then you do it. You don't just grab somebody's hand and poke in, a cannula and be like, okay, I'm giving you IV fluids. It doesn't work like that. Okay, so you give a reason what you're doing, why you're doing, and whether the person understands and they're happy for you to continue. Okay. Consent may be given orally, given in writing, or be implied. The more major the proposed treatment, such as like a surgical procedure or an invasive investigation or medical treatment with potentially serious side effects, the greater the need is that the patient be fully informed, and greater the desirability that the patient's consent be attested to in writing. So in Australia, all the major procedures, operations, or invasive investigations, we need to do a written consent with the patient. So that's something for you to know. Consent is not required in an emergency or in a life-threatening condition. So you can proceed with the treatment unless you're aware of a refusal in a directive or certificate. So sometimes people, especially the elderly, they have an advanced care directive, which is like a book in which they have written their wishes, like DNR, do not resuscitate, or their goals of care. In Australia, this is called goals of care. So are they okay with full, resuscitation, or are they okay with just CPR, or are they okay with giving some drugs, or it's all like A, B, C. So based on each category, the doctor can only do so much based on what the person wants. Consent is not required in involuntary admission under the Mental Health Act. So in Australia, there are circumstances where a patient can be legally hospitalized for a mental illness without consent. They can also be legally compelled to receive treatment medically and/or therapy without consent. So you may have questions around these. So it's good to know this, okay? Who may be legally able to consent? So the person needs to meet two things. One, they need to be competent. What does that mean? Well, they need to be able to understand. They need to be able to communicate their choice. Like, doctor, I'm happy. Yes, let's do this. And I understand, I comprehend what's happening to me. I understand my options and the side effects of the treatment, and I'm okay for you to proceed. Okay, so this is somebody who understands the situation. They also need to remain stable over time. So this person needs to know, needs to be under your care and stable over time. They should not have mood disorders or psychiatric illnesses where they're not, where they don't comprehend properly what's happening. And it's also somebody who is stable. Like if they're saying, I want A, they should say A every day, not, oh, today maybe I want C, maybe I want D. No, maybe I think I want A. So, they need to be consistent. Otherwise, then you question, like, okay, is this person competent? Okay. And then their decision is not as a result of their altered mental status, like delirium, psychosis, intoxication. Okay. And of course, the main thing, they need to be 18 or a mature minor. So what does that mean? So mature minor means when can children provide consent? So the law presumes that people have capacity to make decisions about their healthcare at age 18. Some states have different laws to minors consenting to non-emergency medical treatment. So for example, in South Australia, it's 16 years. In New South Wales, a child aged 14 or over may consent to medical or dental treatment. The legal test that we as doctors can do to determine if a child is capable of giving consent is if he or she achieves a sufficient understanding and intelligence to enable him or her to understand fully what is proposed. And this test is called Gillick Competence. So you can read this online, but you may have a question on this about Gillick Competence. Now, when it comes to parents, parents cannot refuse life-saving treatment for children under 18. Okay? Just because they don't feel like it, that they cannot do that. So under 18, they cannot refuse life-saving treatment. Okay. Do patients have the right to refuse treatment? Yes. So the refusal of, for example, blood transfusion by a competent adult must be respected. So in obstetrics, when I was working in obstetrics last year, I saw like not very common. It's not common, but there's a group of religious beliefs called Jehovah's Witness. They do not accept blood transfusions or blood products. So you have to respect their decision. And obviously you have to make your notes and document that, you know, this is what you did, you tried to explain, and this is what happened. So you have to respect what the patient wants. Now, where parents refuse life-saving blood transfusion for a child, all jurisdictions have legislation that enables doctors to provide blood transfusion in an emergency. Okay, so it's a little different. Competent patients have the right to refuse to consent to a needed test or a procedure for religious or other reasons, even if their health will suffer or death will result from such refusal. So in emergency, like I've seen a few times that say somebody who's got cancer, they don't want to undergo any treatment. They just want pain management, but they don't want to actively undergo chemo, radio, or anything. And you have to respect their decision, okay? And that's a decision coming from a competent patient. And a competent woman who has the capacity to decide may, for either religious reasons or for other reasons, for even sometimes no reason at all, they can choose not to have medical interventions, even though the consequence may be the death or serious handicap of the child she bears or her own death. So again, once again, there's not much you can do, but again, you have to back yourself up medical legally, you have to document and do all your notes, but people have as long as they have the capacity to decide, they can. The opinions of family members, while helpful for information about the patient's state of mind, cannot dictate what information the physician tells the patient. At a patient's request, the family members may present when the physician provides the diagnosis. So if the patient wants their family member to be there, that's fine. But if the patient does not want to be there, then you cannot do anything. So I'll tell you a funny story. So my mother was diagnosed with breast cancer, okay? Now, everybody knew about my mother's diagnosis, but my mother. How funny is that? This was in India, like in Delhi. Like the whole world around us, like all of us family members knew, but my mother didn't know. She had no idea. So we were all talking about it, and I was thinking like, oh my God, this is so absurd. Like you're not telling the patient, but you're telling everybody else. Like, so in Australia, that cannot happen. You have to talk to the patient. You need to inform them. And then it's their decision whether or not they want to tell their family or do what they want to do. Yeah. And my mother is doing well. So just for those of you who are wondering, she's good. She's in good health at the moment. Okay. Substitute decision makers. So when it comes to making a medical decision, if the patient is not able to, then who can? So we have advanced care directive. If a patient has this legal document, we can use that. If they have an agent, like an agent that's appointed by the patient, under enduring like power of attorney, or a lawyer, or somebody that they have appointed, we can use their vote, like, hey, this is what he wants, let's do this. Or another decision maker can be a person appointed by the VCAT. So VCAT is the Victorian Civil and Administrative Tribunal. Every state in Australia has their own version of VCAT. So if there is a person appointed by VCAT to make decisions, we can take that. If there's a guardian appointed by VCAT for health powers, we can take that. If there's an enduring guardian appointed by the patient with healthcare powers, that's fine. If there is a specific person appointed by the patient and there is a writing, like a letter, like this person is able to make decisions about me on my behalf, we can take that. If there is a patient's spouse or domestic partner, that's fine. Or the last thing is like a patient's nearest relative over the age of 18. Okay. So when it comes to ethics, there's a lot of little topics about like close personal relationships, sexual behaviors, how do you work with your colleagues? I mean, you're all smart people. I don't think I need to tell you all this. So I'm just going to skip over this part. Funny thing, when I was in China, I worked in Shanghai for a bit before moving to Australia, and over there it's a culture to give gifts. Like doctors get a lot of gifts, and I used to work in obstetrics, so we, for every delivery that we had, like the patient and the families would give us chocolates and gifts, and that's the culture, that's acceptable. But here in Australia, if somebody gives you a gift, you cannot take it. It's not acceptable. So, okay, if somebody gives you chocolates, then yeah, you can share the chocolates with your team, with your nurses and all the staff that are there, but you cannot take things for yourself and go away. Not acceptable. So a little bit of cultural change when you move to a new country. All right, so question. My favorite part. Yay. You have a 45-year-old female undergoing an elective myomectomy. During her preoperative assessment, she made it very clear that she does not want any type of blood products. Post-operatively on day 1, while in recovery, she was found to have an uncontrollable intra-abdominal bleed and starts to deteriorate. Her vitals are unstable and her hemoglobin is 5. So what is the appropriate next best step? So in the beginning, you remember how I told you I read questions a little differently? So what I would do in an ideal situation is I would read this part first. Which of the following is the appropriate next best step? And then look at the options. IV fluids, provide blood transfusion, apply a cold order, involve the family, give the blood transfusion. And then I would be like, okay, 45-year-old female undergoing an elective myomectomy. During her preoperative assessment, she made it very clear that she doesn't want any type of blood products. Post-operatively on day 1, while in... So, what do you think is the answer? Okay, somebody said A. Okay, so it looks like most of you are, yeah, so A is the answer. So give IV fluids, okay? So obviously you can't lie, you can't hide, you can't involve the family and get their permission. So that's not an option. So give IV fluids, expand the volume, see what you can do to get her stable and see the way forward from there, okay? But as a doctor, your aim would be to do the best that you can within the scope of your practice. Okay. Somebody is saying something. Hang on. So somebody is saying, why not C? So why not C? So involve the family and get their permission for a blood transfusion. So once again, remember I spoke about like consent and also like about sharing information. So there we are. So respect for autonomy. So if a person wants their medical, history or their medical condition private and confidential, you have to respect that. But if they are giving you consent that yes, you can talk to my family, you then by all means can. But in this scenario, there's no information about her giving us consent to speak to her family. If that was there, then yes, definitely we would involve the family and get their permission. But she has clearly made it very obvious that during her pre-operative assessment that she doesn't want any blood products. So in that case, even if you convince the family and the family says yes, you still cannot give her the blood products because that would be going against the patient's wishes. Okay. And about the pre-operative assessment, guys, in Australia, before any elective surgery, usually patients have a pre-operative assessment in which we look at all their health records, their current comorbidities, their medications. We decide what to stop, what to give. Whether they need some new investigations like ECGs, X-rays, some blood work, iron check, all that. So that's the job in the pre-op clinic. Okay. So most departments in hospitals have their own pre-op clinic where they do all these things. Okay. Just bear with me one moment. Sorry, there are just so many messages. So I've got a question from Rajat saying, what if a patient with altered sensorium due to brain mets, family don't want chemo or any treatment, what to do next? So if the family doesn't want chemo or any treatment and the person is not having capacity, so first thing first is how are we going to help this patient, right? So are we adding value, or is this person, like, what is the prognosis of this person? By giving chemo and radiation, are we improving their life? If the answer is yes, then yes, we will try to, make the patient understand. And if the patient is not comprehensive or is in a situation that they can't, then our next thing is, yes, in that case, who has the power of attorney? Whoever has the power of attorney, we can talk to them. And if they say that, the patient's wishes were to proceed with, say, chemo or with radio, then yes, we can. But it all depends on who has power of attorney. Whoever has that, they can make the decision. If there's a conflict and say the doctors are proposing a certain treatment, but the family is opposing the treatment, then you can take that matter to court and they can help in such scenarios. But very rarely this happens. Okay. Usually it all comes down to who has the power of attorney. Alrighty, so moving on, we have 20 most common ED presentations. All right, so if you want to pass the emergency side of things with the AMC-MCQ exam, you can take a photo of this slide because you need to know all of these, okay? So today I'm just going to touch base on chest pain and burns. Wow, it's already 6. I'll be a little quick, okay? But we'll do these two for today, but you need to definitely do all of them. So this is chest pain, asthma, pneumonia. When I say asthma, don't only think asthma, think about shortness of breath as a cluster. So what are all the conditions which can cause shortness of breath? Okay. Then pneumonia, AF. So this whole slide, okay, just take a photo and keep it with you and make sure you cover all of it. Okay, so when it comes to chest pain, so guys, chest pain is one of the most common presentations in emergency. When you start working, you will hear chest pain like 20 times in your shift. So it's extremely common presentation in the emergency department. The underlying pathology can range from something very trivial to something very life-threatening. So as a symptom, it's extremely non-specific. I can be sitting like this and have chest pain, but that does not mean I'm dying, okay? So it's extremely non-specific. And there is an extensive range of differentials in chest pain. So let's try to understand the most important differentials. Whenever I'm thinking about abdominal pain, chest pain, or any sort of, area, I like to break things down in organs. And that way I can easily get my differentials. That's my style, but everybody has their own, that's fine. So over here with chest pain, first thing first is cardiovascular causes. So in that you have ischemic cardiac causes, so acute coronary syndromes, STEMI, non-STEMI, stable angina, severe aortic stenosis, tachyarrhythmias, type 2 myocardial ischemias. Then in cardiovascular, you've got pericarditis, myocarditis, dissecting aortic aneurysm. Then comes the lungs. So in the lungs, you can have pulmonary embolism, pneumothorax, pneumonia, malignancy. Third, what's the next thing is your GI tract. So what can happen there? It can be GORD. GORD is gastroesophageal reflux disease. Some countries say GERD, some say GORD. They're the same thing, okay? Peptic ulcer, esophageal spasms, esophageal rupture or perforations. Fourth, musculoskeletal conditions like muscle strains, rib or sternal or vertebral lesions, malignant invasions like multiple myeloma. Then you've got neuropathic conditions like shingles, then trauma like chest trauma, then rheumatological conditions like costochondritis, rheumatic or degenerative osteoarthritis, and finally psychogenic, so anxiety, panic attacks, all that, okay? All right. You need to know this. You need to know this in every cell of your body, okay? This is like bread and butter every single day. So even if somebody wakes you up in the middle of the night, you need to know this slide, okay? Okay. So let's see what are the risks for chest pain. So like I said, just because I'm like, does that mean like I'm having a cardiac chest pain? No. Can I have a cardiac chest pain? Yes. What are the risks? So each of these conditions, like GI condition, pulmonary condition, rheumatological condition, they all have risk factors. So in history, we want to know, does the stem give us risk factors? Then, we can target on that side. So risk factors for chest pain, especially like cardiac ones, the most common is hypertension, okay? Diabetes, smoking, cholesterol, family history of coronary artery disease. So if you have these in the stem, then please think about a cardiac cause. Other risks for ACS can be alcohol, poor diet, stress, lack of physical exercise, and also see if there's any previous cardiac investigations like ECG, coronary angiogram, thallium scans, exercise stress tests, echo stress tests. So I'll just make life easy. So when we have chest pain in the emergency, we evaluate like the patient, put them in a resus bay, but then we also quickly go and check the record on the computer to see, does the patient have past ECGs or past like reports which I can compare, or which I can get a solid idea that, oh yeah, this is a risk. This person has cardiac chest pain, okay? So this is what I mean by check previous investigations. In hospitals in Australia, like most hospitals, if a patient is admitted and they have ECGs or investigations, all of those will be there. So people can always go back and have a look at what was the history, what all was done, and yeah, we can dig and find things. Then comes pulmonary embolism. So what are the risk factors for pulmonary embolism? So contraception, obesity, obstetrics history, old age, surgery or a serious illness, travel, trauma, thrombophilia, varicose veins, malignancy, and family history. There's different mnemonics. So the one that I remember was COST VMF. There's so many out there. You can pick what works for you. Then pericarditis is previous history of a recent viral illness. Dissecting aneurysm. So these are like, say somebody has a risk of like family history or peripheral vascular disease or hypertension or a known thoracic aneurysm or connective tissue disease or pregnant. So those are your risks. Okay. So if you look at this list, so for GORD, it would be very different. It's somebody with like reflux or with indigestion, with cough. So it's a little vague and different. So these are your main ones, guys. You need to know these risks, okay? Which of the following is the most dangerous to a patient in terms of risk for CAD? So which one do you think? Is it dyslipidemia, breast cancer, hypothyroidism, obesity, or stress? Quick. You can just type the answer. So dyslipidemia, breast cancer, hypothyroidism, obesity, and stress. So A, okay. Yeah. You're right. So the answer is A, and that is dyslipidemia. Oopsie, what have I done? Okay. After showing you this question, I just want you to quickly have a look at the absolute CVD risk chart to make sure it stays in your brain forever. So when it comes to like cardiovascular risk assessment, we have got the Heart Foundation in Australia. It's an Australian thing. You can go to this website, heartfoundation.org.au, okay? Have a look at this website. And over here, you have two charts. So in order to find out whether a person is low risk, moderate risk, or high risk, we need to get a bit of information from them. And in the MCQ, you also have this kind of a question where you need to calculate the risk and answer, pick a choice. Is it A, B, C, D? Okay. So I will teach you how to do that. I'm not sure if you can see my mouse moving, but if you can't, that's fine. So you've got people, at the very top, you've got people without diabetes. On the right side, you have people with diabetes, right? So you can pick and choose the chart based on diabetic or non-diabetic. So let's say my patient is non-diabetic. So I choose the first chart. Then the next thing is it a man or a woman? So I can say it's a man. Is the person a smoker or a non-smoker? So let's say it's a smoker. Then I need to see what is the blood pressure. What is the systolic blood pressure? So let's say that the systolic blood pressure is 160, okay? So I'm here at 160. Then the next thing I want to see is what is their total cholesterol to HDL ratio. So is it 4, 5, 6, 7? So let's say it is 8. So then I am here at 160 and 8. So that makes it red. So red, dark red, is more than 30%. So that is high risk. Okay. Does it make sense? So then it can indicate that, okay, this person having chest pain, they're high risk already for a cardiovascular disease. Okay. So next thing, investigations in chest pain. So there's a few things that, are important. And the first thing first, when we have chest pain, is do a full blood count, do CRP for inflammatory markers. We can check their kidney function, liver function, check their glucose levels, check their troponin. So troponin is one of the most important investigations. In the AMC MCQ, you may get different kind of questions with chest pain. Sometimes they may ask which of the following is the definitive test. So in that case, if there's a series, then always pick troponin for cardiac cause, okay? To rule out, to exclude a cardiac cause, it's always troponin. And then we have got lipase, just to rule out pancreatitis, liver function test. D-dimer, we don't do D-dimer on everybody. We do it if we are considering a diagnosis of pulmonary embolism, and that too if it's a low threshold, like, you know, say somebody like who has risk factors, we can do it, but not standard. And then we look for ECG changes. So say looking for any past ECGs if they're there, or we definitely have to do a new ECG for sure. Then we do chest x-rays. We're looking to exclude, say, pneumonia, pneumothorax, malignancy, or like if it is a perforated esophagus or ruptured esophagus, we're looking for like mediastinal air. So x-rays are important. Then it comes to VQ scan. So VQ scan is done for patients in whom pulmonary embolism is suspected, and CTPA with contrast is relatively or absolutely contraindicated. So that is, I've just put like all the investigations. It does not mean you have to do all of them. I just thought I'll touch base on each one. So that's VQ scan. Then CT angiogram or a CT scan. CT angios are the best initial modality for the detection of, say, a dissecting aortic aneurysm as well as a pulmonary embolism. So that can be done. But if a person has contraindications, then yes, VQ scan. Then we have coronary angiography. So this is indicated urgently in cases of STEMI and in some cases of high risk. Okay. Then the other one is MRI or transesophageal echo. So these are the other options. Then moving on. Question. So Sam has been informed by his GP that he has a potential risk factor for ischemic cardiac disease. Modifying which of the following will result in immediate benefit for him? So what do you think? Like taking statins for abnormal lipids, or managing obesity with aerobic exercise, or discontinue smoking, or taking metformin for type 2 diabetes, or managing obesity with low carb diet? Which one could it be? So there's a lot of questions. I will answer all of these at the end, guys. So somebody's saying C, discontinue smoking. Somebody's saying A. Somebody's saying A, taking statins for abnormal lipids. Okay. So guys, all of these are correct answers, but the answer is, wait, what did I do? Discontinue smoking. So smoking cessation will result in immediate improvement of ischemic cardiac disease risk. Within a year after smoking, after stopping smoking, the risk of CAD decreases by 50%. So smoking is really bad as per, cardiac risk. So that's something that can make a big difference. But all the answers are correct, but immediate benefit would be smoking. We've got a 39-year-old female presenting to a regular GP due to weeks of chest pain that is retrosternal in location with associated burning sensation and nausea. She's found to be systemically well and her vitals are within limits. She doesn't have any major risks for IHD. So which is the most likely diagnosis? Is it costochondritis, pericarditis, pneumothorax, pneumonia, or GORD? And once again, let's have a quick look. What are you guys saying? So E, 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 E. Somebody said D. No, D is not correct. E. Yeah. So E is correct, guys. GORD. So heartburn is a symptom of acid reflux, and GORD, that causes a painful burning sensation in the center of the chest. This sensation can sometimes feel similar to chest pain that people experience during a heart attack or attacks of angina. Okay. Next. 66-year-old female brought in by ambulance to the ED complaining of chest pain, which started 1 hour ago as she was getting into bed. The pain she describes as constant and central in location with radiating features to the left arm and neck. She has some associated dyspnea and nausea. She has a past medical history of anxiety disorder, depression, and bulimia nervosa. Looking at the hospital records, you can see 3 past emergency department presentations due to similar episodes. Which of the following would be the most appropriate next step in the management? I love this question. It's maybe one of my favorite questions. What would you do? And I like this question because we see such things in ED every day. So A, you contact the cardiology registrar to review the patient. B, you get an ECG and send bloods. C, you contact psychiatry registrar to review the patient. D, you give diazepam 10 mg stat. E, advise patient to return home as she is most likely having an anxiety episode. What do you think? B, D, B. What do you think, guys? So B, estrogen bloods. Yeah. Yeah. So C or B. Okay. So, okay. Thanks, guys. Thanks for your response. So look, when it comes to people and ethics, remember how I spoke about the key ethical principles when it comes to medicine? We need to have justice, respect for autonomy, beneficence, and non-maleficence. These are the 4 key things you need to always keep in mind. Now, some people come to the emergency again and again and again, and maybe it's nothing, okay? But that does not mean we should not do anything. So even if it's chest pain and it's the 10th time somebody came in, we are still required and obliged to do everything for them, okay? So you need to get an ECG. You need to send bloods for FBE, UEC, CRP, LFT, troponin, and lipase. And then you can exclude a cardiac cause, okay? And then, yes, then you can contact psychiatry or whoever you want to contact. But if you call a cardiology registrar or a psychiatry registrar and you're like, hi, this is Amrit, one of the doctors from the ED. I've got a patient, 66-year-old. She's complaining of chest pain. Oh, by the way, she came to ED like 3 times for chest pain. And it was nothing. Can you come and see them? They'll be like, I'm sorry, are you mad? Like, what have you done for them? So yeah, so make sure you cover yourself, do all the basic things, okay. So moving on, guys, when it comes to trauma, you need to know a little bit about basic life support and advanced life support. You don't need to know ALS. If you are in your country and you want to do something to improve your resume, please do ALS if you can. It's a little expensive, but if you can do it, do it. But BLS, everybody should have that, okay? So trauma management, when it comes to trauma management, I'm going to share with you guys this resource. I want you to take a photo or go to this link. It's called trauma.reach.vic.gov.au, and all the resources for trauma are here, okay? You don't need to go anywhere else. Then we'll talk about primary survey and secondary survey, okay? So see this over here. So you've got the traumatic brain injury flow chart. So similarly, there's different ones for different injuries and traumas. So all you have to do when you're bored, having tea, just go through these images and download them on your phone, on your computer, and go through them. In all of the trauma cases, the most important thing is A, B, C, D, E. Okay, so this. Even when we're talking in emergency setting, we always follow the ABCD. So always make sure you have a good understanding on ABCD, what that means. Okay. So I won't go through each one of these trauma guidelines, but I really would strongly advise that you do that on your own time. My goal in these sessions that we're having is to give you resources so as you can read on it on them in your own time and you have access. So it's nothing hidden or a secret that I want to keep in my own computer. No, you should, if it's available, you should have it. Okay, so go through it. Then we've got BLS. So BLS is basically DRS ABC, D. So danger, responsive, send for help, open airway. Are they breathing or not? Is it normal breathing? Great. Then you need to know the standard CPR. So 30 compressions to 2 breaths. That's standard. There are a few MCQs around BLS. So make sure you know this topic really well. And you need to know where to attach the defibs. So do that as well. So read about it. And a good way to read more about BLS is this link. Go to ANSCORE, then the Australian and the New Zealand Committee on Resuscitation. So go to their website and you will get a lot of information on resuscitation, first aid management, BLS. Okay. Okay. So causes of unconsciousness. So say somebody is unconscious, what could be the cause? So we can classify these into 4 groups. The first is low brain oxygen levels. The second is the heart and circulation problems. The third is metabolic problems. And the fourth is brain problems. Okay. So if you can keep these 4 in your mind, you can at least be safe. Okay, and a combination of different causes can happen, no doubt, but keep these 4 in your mind always. Okay, let's go to this question. 29 years old female is brought to emergency department with unconsciousness. Her airways patent and breathing without difficulty. Her blood pressure is 125/80. The pulse is 110. She's a bit tacky. Oxygen is 99 on room air. That's good. And temperature is 37.5. Which of the following is the next best step? So would you order a CT brain? Would you order a chest x-ray? Would you order a VBG, order an ECG, or check the patient's GCS score? What do you think you would do? Anonymous attendee is saying GCS. Yeah, you guys are right. Yay! Okay, you guys are right. Yes. So we check the patient's GCS score. Okay, good. So GCS is used very, very commonly, and it has to be because it exists here. Okay. So this is a normal observation chart that we use in hospitals. So you can see here on top, full name, date of birth, date of admission. This is just a standard one. It's not specific to a hospital, but just to give you an idea of what it looks like. Then we've got the breathing here on top. So the respiratory rate. Then we have got the saturation over here. So up where it's date and time, somebody would write the date and the time. So say you tell the nurse, I want every 15 minutes obs or 5-minute obs. So then she will keep going every 5 minutes and plotting, like making a little circle in each of these boxes. Okay, then we've got is the patient on oxygen? If they are, then write how many liters. Then the blood pressure, like what is the reading? So you can put a little dot at the systolic and the little dot on the diastolic and make an arrow. Then we've got the pulse. So you can make a little dot where the pulse is. Is it 91 to 100 or 100 to 120, whatever. Then consciousness. So this is where you have your GCS. So that comes here, and temperature. Okay. This is a standard OBS chart. Okay. Are we going well? Are we okay? Why not CT brain, as patient is unconscious too? So CT brain is a different, CT brain, yes, you will do it. Definitely you will do it at some point. But first you want to see, what is the GCS? Is my patient a GCS 8 or below? Do I need to intubate? So, like you first have to go A, B, C, D. So this brings me back to DRS ABC. So always we need to look at the patient from a ABC point of view, like are they still with me? Are they still like manageable? So to put somebody in a CT brain, that's like at least half an hour for them to be in a machine. What if they have a cardiac arrest and they die there? So, is it safe for me to send the patient into a CT? So I need to know the GCS first, and then put it in the observations, and then make sure the vitals and obs are all stable, and then go next. Okay, so next, primary survey. So the primary survey is the initial assessment of a trauma patient, and it involves A, B, C, D, E, okay? So A, B, C, D, E, airway with cervical spine control, breathing, circulation, and circulation including the control of external hemorrhage, disability, which is your mental state, and exposure. The purpose of the primary survey is to rapidly identify and manage impending or actual life threats to the patient. Sorry, guys, I said we will finish at 6 and it's 6:30. I'm going to try to wrap up quickly, okay? And I'm very sorry if I'm holding any of you guys back. But I hope this is useful for you. Okay. Alrighty, then comes secondary survey. So secondary survey is performed once the patient has been resuscitated and stabilized. It involves like a very thorough head to toe examination, and it aims to detect other significant but not immediate life-threatening injuries. Okay, so say somebody had a trauma, they are like worked up from like a primary survey and now they're stable, we can then do a secondary survey. So what do we want to know in a secondary survey? So the history, okay? For history, the mnemonic that we use is AMPLE, A-M-P-L-E. Oopsie, what did I do? Allergies, medication, past medical history, including tetanus, last meal, events leading to the injury. So what happened? Did you become unconscious? Before that, what happened? Okay? Then a very thorough head to toe examination. You're going to touch and feel and examine each and everything from head to toe, making sure you can clear them. So from a trauma point, a secondary survey is like a little sheet in hospitals, which we can take, and then we can keep writing our notes and clearing off everything and showing in the document that we have done a complete secondary survey. And once we've done that, then we can clear them from the caller. Okay. And of course, then documenting and planning. Sometimes it can happen that you're doing a secondary survey and the patient deteriorates and becomes, unstable. Then what do? Then you go back to your primary survey. Okay. You go back and repeat this A, B, C, D, E. You always go back. Okay. Okay, burns. Let's go to burns. All right, so burns, the initial approach, ensure safety for rescuers, bystanders, and the victim. Do not enter a burning or toxic atmosphere without appropriate protection. Stop the burning process, stop, drop, cover, and roll, okay? Smother any flames with a blanket, move away from the burn source to a safe environment as soon as possible, assess the adequacy of airway and breathing, check for other injuries. Is it safe? And if you are trained to do so, you can give oxygen to the victim, especially a victim of smoke inhalation or a victim with facial injuries. And SCORE has good guidelines. So once again, I would recommend go to ANZCOR, the website, and you can get more information. You can call for an ambulance. The aim of first aid treatment of burns should be to stop the burning process. So cool the burn and cover the burn, okay? Protect the area. This will provide pain relief and minimize tissue loss. How do you evaluate burns? So there's a few things that you can do. There's a few charts which different hospitals have. So to evaluate the extent of burns, you have the rule of palms. So the rule of palms means the surface area of the patient is approximately 1 BSA. So say the burn area is irregular, it's like a little bit here, a little bit there, then you can use the palm, okay? The other thing you can do is the Wallace rule of 9s for adults. I think I have put, there, the image here. So this is from the Alfred, which is one of our major burns unit in Victoria. So that's the rule of 9, and we can use this to calculate what is the extent. So head and neck is 9%, each arm, including the hand, is 9%, so 18% for both. Each lower limb is 18%, so 36% for both. The front of the trunk, the chest and abdomen, is 18%. The back of the trunk, the chest, abdomen, and buttocks is 18%, and the perineum is 1%. Okay, and then you've got the Lund and Browder chart for children, which is like this. So in this one, it depends on the age. So 1 year, 2 year, 3 years. So the percentage keeps changing. So that's something from depending on age. There are a couple of questions on burns on the AMC. And if I'm not mistaken, in the handbook as well, there are some questions. So you can have a look. But I thought you need to know these, like the rule of palms, the Wallace rule of 9s, and the London Browder chart. So these 3 you should know. Then what do you do? So there's different types of burns, okay? So somebody can have a heat or a thermal or a contact burn. So these can be like a flame or a scald or a blast or an inhalation injury and direct contact. So in this case, the best thing to do is immediately cool the burn with cool running water. And ideally, this is for 20 minutes as per the ANSCORE guidelines. And if possible, remove any jewelry, rings, watches, all that, or constricted items without causing further damage. Remove any wet, non-adherent clothing. If something is stuck to the skin, don't peel it off. But if it's non-adherent and if it's like soaked in hot liquid, then try to get it off. Cover the burnt area with a loose and light, non-sticky dressing, and cover the unburnt area as well to keep the person warm and avoid like loss of temperature. Other than this, you can elevate the limb to minimize swelling. Do not peel off clothing that is stuck to the skin or like a burning substance. Do not use ice or ice water to cool the burn, as you can cause more damage by using ice. Do not break any blisters or, like bubbles. Don't do that. Do not apply lotions or ointments or powders other than hydrogel. Then we have inhalation burn. So, okay. So always assume inhalation injury if there are burns to the face. So in this whole burns segment, if you can remember anything, it's this slide, okay? Inhalation burn, very important. So it's the most dangerous one because it can mess up the respiratory tract. And if somebody has burns on the face, on the head, always, always, always suspect inhalation burns. So if you see that the eyelashes, eyebrows, the little hair in the nose are burnt, definitely red flag, okay? So we look for carbon deposits around the mouth or the nose, if they're coughing up black particles, if the voice is becoming hoarse or they're having difficulty breathing, then this person can go into a breathing emergency, okay? So be very careful. This is where the question is. So anybody who is in an enclosed, trapped space with hot toxic gas or steam or fumes, we suspect inhalation burns in them. And do not assume like the burn victim is stable, if they've got like an inhalation injury, because they can be breathing at the moment, but within a few seconds they can stop breathing. They can, have like a collapse, and then it's too late. So always focus on airway and breathing. Again, ANSCOR guidelines, really amazing. You can check it out. So what to do? Get this person to a fresh space with fresh air. Give them oxygen if you're trained to do so, and call for the ambulance. Electrical burns. So electrical burns include lightning. They can also involve complications, especially cardiac arrest. So if somebody had an electrical injury or electrical burn, the main thing to do is turn off the power supply without touching the person and start CPR if, they've gone into arrest or if they're unconscious, and follow the BLS guideline. Okay. And if they have evident visible burns, you can cool the area with cool running water for 20 minutes. And if you are trained, then definitely you can give them oxygen, call for the ambulance, and keep going with CPR until help arrives. Chemical burns. So this we see, I would not say frequently, but it happens often with emergencies, like emergency presentations at the hospital where, like, say somebody's working in a factory and they had exposure to chemicals which burnt them or got into their eyes. So in this case, what do we do? So this type of burn, it's common, and the first aid is not to cool the burn, but to dilute the chemical, to get the chemical off. So if it goes in the eye, we try to push in lots of fluids to get the chemical diluted. Okay. So you don't put ice on the eye. You try to wash it out, do an eye wash. Avoid contact with any chemical or contaminated material, and use PPE to protect yourself. Get the person to a safe area. Remove any chemical or contamination on the clothing or jewelry or whatever is happening. If there's brush powdered chemicals, then try to get them off the skin without spreading them everywhere. And basically simple common sense things that you can do. If, like I said, the chemical enters the eye, then you can flush the eye with water. And the flushing is more important than calling for an ambulance or getting them to the hospital. So try to dilute that chemical as soon as you can. Okay. And most people who work in industrial areas or with chemicals, poisons, they usually have safety data sheets. Okay, and it says what to do for a certain chemical. So if you don't have this information, that's fine. You can always call poisons. So in Australia, if, say, a child swallowed like a chemical, like, say this was like a bottle of hand sanitizer, but maybe something else mixed in there, and I don't know what was mixed. And as a doctor, I'm not sure what to do. So I will call poisons. It's a service, okay? It's another department. So I can get information from them, say that, I've got a 4-year-old who accidentally ingested Dettol hand sanitizer, which has alcohol, it has glycol, it has a lot of crap. What do I do? So then they will guide you what to do, okay? So it's called Poisons Information Center. Every state has their own. Alrighty. And do not attempt to neutralize either acid or alkali burns, because this will increase heat generation, which may cause more damage. Do not apply cling wrap or hydrogel dressings to chemical burns. Okay, investigations in severe burns. So what do we do? So first, FBE, UNEs, glucose, blood group, and save blood, okay? If indicated, if they're really like going down the hill, then we do ABGs. So I would like you to go on this ANZBA website. So maybe write this down, ANZBA. So over here, once again, there's a beautiful guideline on the management in severe burns. So it talks about, I will tell you what it is, but I just want you to also know that there's a resource called ANZBA, Australia and New Zealand Burns Association. Yay, go there. Okay, what do you do to manage severe burns? So first thing, airway. ABC, remember always. Airway. So oxygen therapy, especially for inhalation injury or carbon monoxide poisoning, give 100% humidified oxygen. Intubation for extensive facial oropharyngeal burns should be done before significant airway problem develops. A patient with a history of signs suggestive of inhalation injury requires careful and repeated assessment of the airway over time if they're not intubated. So second thing we do is check breathing. So treat any bronchospasms, pulmonary edema, carefully assess the chest. Deep circumferential burns of the chest or abdominal skin can restrict chest expansion and compromise ventilation. Escharotomies may be required. Then next thing is circulation. So for circulation, we need IV lines. So make sure 2 large IV cannulas are inserted. And people who are shocked, we need to give them initial fluid bolus, resuscitate them with fluid, and assess the extent and depth of burn to, again, estimate how much more fluid we should give them in 24 hours. And the fluid of choice is usually normal saline or Hartmann solution. And how to calculate how much fluid to give, I have made a slide for you here. So there's the Brooks formula, the Parkland formula, and the consensus formula. So this comes in the exam sometimes. It's one of the topics, and it's there in the handbook, if I'm not mistaken. So please keep this in your to-do list. So understand all these 3 formulas: Brook, Parkland, consensus. Okay, so then the next thing to do is analgesia. So somebody with severe burns will need opioids, so morphine. Make sure that, we've got monitoring in place. So what I mean by that is not just the simple monitoring of heart rate, temperature, pulse, blood pressure, all that, no, but also their IDC. So have a indwelling catheter to check the urine output. So you're giving fluids, right? You also need to monitor the output to see what's coming out and whether there's a balance, what's happening, and also continuous ECG and core body temperature. Somebody with severe burns, especially facial, may need an NG tube. It depends on the clinical scenario. So I will just put that there, but not everybody needs an NG tube. Then wound management and debridement, again, depending on the scenario. When it comes to dressing, so depending on the scenario and the transfer to the burns unit. So say if somebody is going to be transferred in less than 6 hours, we can use burn shield, which is a thing, and cover the burnt area with cling wrap, with the plastic cling wrap, the one that you use to cover food, like leftover food at your house. So that's cling wrap. So you can cover the burns longitudinally, with cling wrap. And if you think the transfer to the burn unit will happen more than 6 hours later, then you can use paraffin gauze or a silver dressing, which is easily available in all hospitals. Important to protect the person against hypothermia using a space blanket. Check for tetanus and give tetanus prophylaxis if indicated. IV omeprazole to protect from stress ulcers. And then finally, once they reach the burns unit or later, then they may need surgical grafting. So this again is for full thickness burns or deep partial thickness burns which fail to heal. Okay. So if a burn is in a children, the formula is different. If it's an adult, the formula is different. So you can take a photo of this if you want. But yeah, usually it's 2 to 4 ml per kilogram into total burn service area over 24 hours. So we usually give half of this volume in the first hour and then half of this in the following 16 hours. And to the above, you must add the usual maintenance requirement as well. And for the adult, it's more or less, again, 2 to 4 mils. So you can follow these better, the Brook, Parkland, or consensus. So just keep that in your mind. A question. A 38-year-old man sustains burns in a farmhouse in a farmhouse fire as he ran inside a burning room to open access for his farm animals to escape. The animal's shed was full of smoke. He was burnt on his face, head, chest, back, and arms. The burns were partial thickness involving more than 30% of TBSA, total body surface area. When assessed, he speaks in a husky, hoarse voice, and his facial and scalp hair are found singed. Which of the following actions should be undertaken first? Should we do an endotracheal intubation? Should we insert an IV cannula? Should we put silver sulfadiazine dressing? Should we give him antibiotics or should we give him morphine? What do you think? So most of you are saying A. So Rashwin is saying cannula first. Okay. So what if you're doing the cannula and the patient can't breathe? What will you do? Yeah. So yes, there's a risk of inhalation burns. So once again, guys, I just want you to come back here. Everywhere I'm showing you A, B, C, D, A, B, C, D. Airway is always first, okay? Airway, open airway, airway. So airway takes the first priority over C for circulation. C for circulation is important, but not as important as A for airway. So I take a breath in, I take a breath out, but if I don't take a breath in again, that's not good, right? So this person needs airway secured. And because he is burnt in so many different places, especially the face, we are worried that he may deteriorate. And in that case, airway needs to be managed. So airway stability should be assessed rapidly in burns involving facial or suspected inhalation injuries, particularly in the early period following injury when airway is at risk of obstruction due to the swelling, okay? It's important to identify early those who may require intubation as it becomes increasingly difficult with the development of edema, especially once fluid resuscitation has commenced, which cascades the swelling. So A, B, C, airway always first, okay? And the burn involve his face, his hair, his eyebrows are singed. So that's a sign that his airway can be compromised. And he's speaking in a husky voice, which suggests that he has already developed laryngeal edema and can shortly lead to airway compromise. Ventilation with inspired air of oxygen content will then be possible. If, you know, we are not intubating this person, you can have a bag and mask ready just in case. But IV access, like somebody just said, is important, but does not take precedence over airway, okay? And yes, he will need all of these things. He will need antibiotics, morphine, cannula, silver dressings. Everything is important, but not as important as airway. Okay. So again, suspect inhalation injury if there's exposure to fire, smoke, if the voice has changed, there's hoarseness of voice, there's a harsh cough or stridor, burns to the face, singed hair, eyebrows, lashes, soot in saliva, sputum, nose or mouth. Other than that, I think that's it. Consider intubation if there's signs of pending airway obstruction, decrease, GCS. If the decreased level of consciousness, again, you need to consider intubation. Unprotected airway, airway is at risk in transit, uncooperative, combative patient leading to distress and further risk of injury. So always consider intubation in all of these scenarios. All righty, so I think that is it for today. Some of the references from today. What I would request you to do is a couple of things. So first, go to those links which I've shared with you today, please, and have a look, have a read. Second, develop the habit to sit for 3.5 hours. So if your exam is coming or you're planning your exam, you need to have the ability to sit down and focus for 3.5 hours. So that's very important, especially with this new age of Instagram and TikTok and Facebook. We're so distracted. So focus. Then when it comes to preparation, please read the AMC handbook. This is a book which is 100% gold. Definitely go through it, read it. If you're new to the AMC preparation, read it as if you're reading, any book, and then read it again as if you're answering the questions, and then read it again. Now you're understanding why is that the correct answer. Okay, so please do that. With OSProEd, we have got a YouTube channel which does not have any MCQ videos yet, but I am going to be uploading a lot of MCQ videos on there. So feel free to sign up, or what do you call that? Subscribe to that. And if you enjoyed today's session, please leave me a comment in the Q&A. And I would like to know if there's any specific topics that you want. Also, if there's any specific problems that you're not able to cope with, or you think it's really hard, we will try to make it easy. The next session will be again on Thursday next week. And I will be a bit better prepared with time, because today we've taken almost 2 hours. So sorry about that. I'm very sorry that I took too much of your time. I hope this was useful, and I hope that I will see you next time. And if you have any questions, ask now. Thank you so much, guys, for your kind words. Afrin, you're saying ECG is very hard. ECG was very hard for me as well. So what I'm going to do is I will get my colleague to teach ECG, and he is really good. So I would not teach you something that I'm not good at. Remember I told you swimming? Learn swimming from somebody who knows how to swim. So if I teach you ECG, I'm going to drown you. I'll only teach you what I know. What I know, I can confidently give you. But don't worry, we will cover ECG. See, medicine is like an ocean. The more we swim deeper, the more there is to the depth, and you can't know everything. There's so much to know. So that's why focus on your strengths and make those really, really strong, and then be aware of your weaknesses and focus on those. Okay, if you're aware of your weaknesses, you can fix them. That's not a problem. So somebody wants basic fluid management. Yeah, please send messages on what all you want. What question bank would you recommend? So Sarah, before going to any question bank, the first best question bank is the AMC, the handbook. The handbook is so important. You know why? Because every question has 5 differentials. So you are not only covering one topic, but you're also covering 5 topics within the question. So that would be my first recommendation. And after that, there's Amadex, which is good. There's a lot of other question banks. But for you to read the question and those 5 topics within that AMC handbook, within one question, those 5 topics, those 5 scenarios, and understanding them, understanding what it means, will help you to pass any exam. Because say if you understood those topics within the question, and the question in your real exam is a little different, you will still be able to pass it. You know why? Because you have the knowledge. You know what it is, you know the disease, you know the investigations to order, the differentials, what not to do, what are the complications. So you will never fail. And say if you passed your exam after the MCQ, you will easily also get a job because you already have the knowledge within you, and passing the clinical exam becomes easy. So most people struggle a lot with passing the clinical exam because they've done a lot of cramming for the MCQ, and clinical is all about explanation. It's all about explaining the patient in simple words what it means to have hypertension, what it means to have a heart failure, what it means to have a certain disease, what are the differentials. So in that exam, you cannot fake it. Okay, you cannot fake it. You need to have the knowledge. There's no escape. Psychiatry. Oh yeah, I like psychiatry. Happy to do topics on that. Ethics sources, please, if you can share. Yes. So ethics, the book that we have, just a moment. So there's a few. So there's a book called the AMC Ethics. Sorry, not AMC Ethics. It's called Good Medical Practice. So you can download that. The RACGP has also very good resources for ethics. So today, because I planned this to be a 1-hour session, I did not cover a lot of ethics apart from like consent and basic things. But ethics itself is like an ocean, but 1 or 2 questions every now and again, I'll keep throwing them in there into the session, and hopefully they'll help. The Good Medical Practice and RACGP are good resources. You can go through to them. Somebody said entertaining session. Okay, so maybe I can have a career in acting. Thank you. Metabolic disorders, yeah, definitely metabolic disorders. And inhalation injury, how do intubate without sedating the patient? Do you need cannula? Yes. So, okay, good question. So inhalation, somebody's asking, in an inhalation injury, how do you intubate without sedating the patient? Do you need a cannula to give medicine? Good question. Okay, definitely, yes, you will need to sedate the patient. What they're asking you is not whether you need a cannula first or you need to sedate first. They're asking your thought process, like what takes precedence in an emergency which involves suspected inhalation. So in this case, the criteria is A, B, C. So airway is always number 1. That's what they're trying to get at. And they do not expect you to do an intubation. That's beyond your scope. Okay, intubation is not done by interns or resident medical officers. It's done by senior registrars and consultants who have the skills to do airway intubation. Okay, so they're not asking you for that. It's more about what's the priority. So one more thing, guys, keep in mind this exam is at the level of intern HMO. Okay, so many people fail AMC because they, in their home countries, they're specialists, they've got years of experience, but when they do this exam, they think at the specialist level, and it becomes very difficult because the AMC is testing you at the level of an intern. Okay, so interns are usually like iffy biffy, not very sure what's happening. It could be this, it could be that. They're very good with differential diagnosis, so they know their differentials really well. They know that they can ask for help. So open to communication, open to help. So that's the level they want you to be at. Okay. Can you please share PDF link for AMC handbook? Shirin, I don't have such links for any handbook. You need to invest in an AMC handbook. So you can buy one. You're going to spend a lot of money to sit these exams. So it's a very important resource. And I would say buy a handbook. You can buy it directly from the AMC website. My handbook was, at the end of my preparation, it was full of text because I wrote in it. I was like constantly reading, writing, doing all sorts of, drawings and making my own drama in the book. So at the end, it was only I could understand what I've done with the book. So you need to own a book. You need to have your own handbook. because I would suggest read it 3 to 4 times at least. Read it as a storybook, read it again, looking at the each question's conditions, like conditions in the sense in the options. So read all those, then go back and read those topics, then third time, try to solve the question. Okay. The way I solved it was I took a pencil and I marked my answer like B. Then I would finish that one first segment, go back, check the correct answers, and then see where I did wrong, rub it off, and then redo it again. So I was just like obsessed with that book. So you need to own your book. Do not go for any stupid PDF links and all that stuff. Where do I start the preparation according to the subject? Start anywhere, man. Just start somewhere, it doesn't matter, but you have to cover all those topics. Please tell me important topics we should cover from JM. So look, JM is a great resource. And you've got very simplified versions of most conditions in the JM. I'm a huge fan of the JM. So look, these are the 21 like 21 topics you need to focus on, and in each topic like say dermatology, there's a lot of diseases. In ENT, like there's a lot of conditions you need to know. So focus on subject and then get as much as you can. Don't read JM like a storybook. Don't do that. It's not gonna stay in your brain. So when you go through the handbook, you see a particular condition, then go to JM and read that condition and understand it. Will you cover psychiatry? Yes, we can. Easy peasy, no worries. Is JM necessary to study as I have only 2 months? Yeah. So JM, look, once again, you don't have to study JM as a like ultimate book. It's a good resource. So whenever you're trying to understand a topic, so for example, we did Burns today, right? You can go to JM and have a quick read of Burns, see what's there. Or if you're stuck with a certain question in the handbook, go have a look at JM. If you're not convinced, why does this answer feel wrong? Why did I answer this question wrong? Go read JM. So like that, okay? So somebody asked, a pregnant lady in labor refusing to undergo C-section, which is safer for the baby, and she's asking for a normal way of delivery. What to do in this situation? So look, in a situation like this, doctors would go and speak to the patient, explain to them the risks. What are the indications for the C-section? Why are we doing that? What are the potential complications? And it is a surgery, so you need to explain to them indications, the pros, the cons, make them sign a consent. But if they don't want to go through it, and they are somebody who's competent and they are willing to risk having a dead baby, then you can't do anything. And if they're willing to die in this process, you can't force them. Okay? So you can't sedate them and like force them to have a C-section. That's against the law. So recommendations for somebody with a 5-year gap. Okay, so first of all, do not listen to anybody with all the things people are telling you with the gap. That's fine, because many people have like women especially, they have children, they focus on their life and priorities, and that's fine, So if you have a gap, that's okay. Just focus on how you can come back on track. So see if you can do CPD activities, see if your ALS, BLS is up to date, do some observerships. It depends on what country you're in. Like if you're in Australia or somewhere else, the best way to cut down on your gap is by doing CPD activities. There's a lot of free resources online that you can access. And you can do like small courses and gain those CPD points and show that you're, recent and you're active in your learning. Mm. Do we conduct paid AMC MCQ courses? Yes, we do. So OSProEd on our website, they're there. I would personally recommend, before signing up to any course, first make sure that you read the handbook. It's very important. Go through it first, okay? Because you need to spend the time and effort on your own. Nobody can force you or sit with you and go through handbook, and that's like a waste of your money and time. So take the time off, read the handbook. Once you're done with the handbook, see how you feel. If you feel like, you know, you're ready to take a course, or you feel like, okay, you know what, these are my areas of weakness and I will benefit from a course, then yes. Some people don't need any course. They're completely, you know, like pretty good with their knowledge. And again, guys, some of you may have way more knowledge than I do. We're all different people. We all have our own strengths and weaknesses. I can only share what I know. And I'm pretty sure you're all like fantastic doctors in your own spaces. But to pass the exam, this is something that I have been doing. I can share what I know. But if you don't agree with something, or you feel there's a better way, you're right. There may be. And you're more than welcome to try something else, but do not give up. Okay? So definitely keep going, keep studying, keep after it, and you will pass your exam. Have an open mind though. Handbook is sufficient and refer for handbook is like basic. Handbook is not sufficient on its own. It's the baseline. You need that. It's your foundation. Remember how I said to build a house, you need to have a proper concrete foundation. So your handbook is your foundation. So each question in the handbook gives you the opportunity to focus on so many, like each question gives you the opportunity to focus on 5 presentations. So focus on them, read them, make your baseline strong. So again, another question about gap. So again, guys, gap, don't worry about your gap. Focus on studying and doing CPD activities. Is there a fixed time period to do AMC 2 after AMC Part 1? Look, it depends on you. Ideally, a person would need 3 to 6 months to prepare for the AMC Part 2. The reason why is it's an expensive exam. It's a very difficult exam to pass. The failure rate is quite, high. So unless you are confident, I would not recommend going in for it. If you're somebody who works in Australia, you know the healthcare system, by all means, go for the Part 2. Okay. But if you are new in Australia and you've just passed your Part 1, take your time, be sure, and then do it. Because what happens is when people fail their clinical, their confidence goes down, their morale goes down, they start to lose hope. So do it in one go, but do it the right way. Make sure you're confident, make sure you've covered all the topics. It's not a game, okay? Is it beneficial doing medicine and surgery appointments for internship over pediatrics and gyne and OBS for AMC? I think for your internship, you need to cover everything. At least I had to do everything. I'm not sure about you. Yeah, you have to follow whatever your university has for the internship. I'm a final year medical student. Can I get internship with AMC 1 in Australia? So in order to do the AMC, you need to have a medical degree first. Okay. So if you've got a medical degree, yes, you can apply for the AMC, register, get your documents verified by EPIC, ECFMG, and then you can qualify to sit the exams. So look at that process, please. Okay. All right. So, guys, I will go now. When will be the next session? So, I'll do the next session next Thursday. And from the topics that you guys have recommended, I'll pick some and I'll do it. And I think 1 hour might be a bit too less. We may do 1.5 hour. I'll let you know. I'll send out an email to you guys early next week and keep you posted. Maybe you can do some reading before the class. That way, if you have specific questions, you can ask on that topic. Okay. All right. So it's dinner time and I will go. You guys take care. I hope this was informative for you and look after your health and feel free to message if you have specific questions. Okay. All righty then. Take care. Oh, somebody's saying, is it possible to get a job with AMC1? Yes, yes, yes. It is possible. That is why you have to study really well. That is why this exam is so important. You really have to have a good, solid knowledge to pass. And what happens is people pass the exam, but they don't get job interviews. Or if they get job interviews, they don't pass the job interviews. Because in the job interview, they give you scenarios like, you're a doctor, this is the situation, what will you do? And over there, there's no recall. You have to use your brain. You have to explain logically, structure-wise.